All right, next up we have Dr. Tom Randall, who's a gynecological oncologist at the Mass General Hospital and a senior advisor for gynecological cancers at the National Cancer Institute Center for Global Health. His interests in global oncology are optimizing and scaling up cervical cancer screening and in capacity building for treatment of gynecologic cancers in resource-limited settings. He also has an interest in building capacity for minimally invasive surgery in low-resource settings. He is currently working on projects in Rwanda and in Uganda. Dr. Randall works as a volunteer for the Dana-Farber Cancer Institute Center for Global Cancer Medicine, and he also serves on the advisory board of Global Oncology. And I think, yeah.
Thanks a lot, guys. Thanks for coming out. I think for the clinicians here, it's really a great thing to sort of have the opportunity to think about collaborating with you as a group and to be able to air our grievances. And that's kind of the approach I took to this talk. I'm a cervical cancer sort of expert slash zealot. I think cervical cancer is a bad disease. It's every cervical cancer death, as I will show you, is something that Paul Farmer would consider a stupid death. It could be prevented, it can be treated, it can be prevented at a number of different levels. So the approach I took to this, and Franklin really said most of what I'm going to try to say more articulately, which is typical, but I'm going to try to take you on the journey that I go through as a clinician and show you some of the pain points that I have. And I'm particularly in this going to focus on treatment of invasive cancer rather than looking at scaling up screening, which Rachel's going to address in a minute. And so if we think about cervical cancer, and Franklin showed this to some extent, but there's a divide in cervical cancer between the rich world and the poor world, and between the north and the south. And you can see that the darker colors are higher and really fairly drastic levels of cervical cancer mortality as you go into lower middle and lower income countries. And if we look at that in the sort of worldmapper.org point of view, which is by making a pictogram of cervical cancer deaths by country rather than land, so that the size of the country is their cervical cancer deaths rather than land mass, you can see that the US and Canada basically disappear, and what you see is sub-Saharan Africa, some of South America, and South Asia. And interestingly, if you compare that to the pictogram of the number of people living on less than $10 a day, it's the same map. And so cervical cancer is an unbelievably damning example of global inequity in healthcare. That this is a preventable and treatable disease that we let the poor die of in droves. So there you have it. The disease is known to be caused by human papillomavirus, and this will be addressed, but the reason for showing you the viral capsid of human papillomavirus there is that one of our challenges is that the way we found so far to diagnose this infection is by DNA. And when we talk about point-of-care diagnostics, what we really need to be able to do is purify DNA and do PCR in a jelly jar out in the field. And that's obviously not easy, but we'll talk more about that in a while. I'll let the basic science of HPV go. I want to show you the picture of Henrietta Lacks, because you can't talk about invasive cervical cancer without talking about Henrietta Lacks. And there's a social justice issue, of course, to the use of her cells in basic science and clinical science research for generations without her family's knowledge or consent. But it's also classic because Henrietta was of low socioeconomic status and in the 60s was not getting screened for HPV. I'll skip that, but we have what we deal with then is initial HPV infection going on to continuing infection with some people developing precancerous changes in cells on their cervix, and then ultimately a small minority progressing on to invasive cancer. And you see that if you look at this, the left graph is the group of people who start with an HPV infection. Out of them, over 3 years, a very, very small proportion will develop a high-grade pre-invasive lesion on their cervix. And out of that tiny group, you then go to the second graph. And an increasing number of those people from the tiny group develop cancer. And ultimately, that gets to almost 50%. Don't ask me how we actually know this. We do know this. It happened about the same time as the Tuskegee studies, but interestingly, somewhat after. And if you want to know more details about that, we can have a discussion later. But another shameful moment in human science. But the point being that part of the trouble we have with screening, as you'll hear in a minute, is that needle in the haystack of finding those people who are going to go on to be at risk of cancer out of a very large number of women who have a human papillomavirus infection. But I promised I would just talk more about invasive cancer. And because we have screening in the U.S., the majority of women in the U.S. present with either localized or regional disease. So over about 3/4 of women present either with a cancer, who present with an invasive cervical cancer, present with cancer either in the cervix or in the cervix and immediately adjacent tissues and lymph nodes. And the vast majority of those women can be cured with the technology we have available in high resource settings. And you can see that here in the survival graph where patients with localized disease are cured more than 9 out of 10 times. Patients with regional disease, so even with spread into adjacent tissues or the lymph nodes, about 2/3 of those women can be cured. Women with distant disease are less often cured. And that's a great concern when you look at not only the resources that are available in East Africa, but at the presentation of patients because of the lack of screening and because of the lack of our ability to diagnose even women with invasive cancer and then get them to evaluation and treatment in a timely fashion. And so what we've seen at the Butaro Hospital in rural Rwanda is that only 3% of patients have disease still confined to the cervix that's surgically curable when they're seen at the hospital. So that if you think about this spectrum of cervical cancer control, this is again the inequity of letting women die from this disease, because we have all of these different moments at which we have an opportunity to intervene and save the woman's life. They can have vaccination before HPV infection. They can have screening at the development of high-grade intraepithelial disease. They can have earlier treatment with timely evaluation and diagnosis. They can have treatment, definitive treatment of their disease, and then beyond that, there's a tragedy of women who present with advanced disease and don't have access to palliation. And so those are really identify my pain points with cervical cancer in the low resource world, and particularly in my experiences in East Africa. So we have trouble identifying the patients at risk out of the mass of patients who come in. For example, in Rwanda, they have a degree of universal health care, and they have an extensive network of community health workers and health clinics. And so women will often be seen for abnormal blood pressure or corns or headache, and will be sent home, and a year later will be found to have a stage 3 cervical cancer, which we know clinically takes 3 or 4 years to develop from pre-invasive disease. So they're passing through a medical system without an effective intervention. So there's a failure there. There's a challenge with evaluation of patients with pelvic examination and taking a biopsy. Challenges with timely histopathology and tissue diagnosis. Then there's a need for a selection of treatment, and that includes neoadjuvant chemotherapy for patients with locally advanced disease is available in low resource settings. A need for safe surgery, but they need to be referred in a timely fashion. A need for chemoradiotherapy, which for patients with regional disease is definitive treatment and can often be curative. Need for adjuvant treatment for patients at high risk for recurrence after initial treatment. The need for palliative care. And then, because these are people, and we're not going to say, well, this is Africa and you should be grateful for your little bit of malaria treatment and move on. The other thing we need to be aware of, and be aware of early, because we were not discovering it like we did in the Northern Hemisphere in the 20th century, is detection and management of the effects of care. So identification of the patient. In the center of the picture is Dr. Groesbeck-Parham, who's probably, one of the greatest people in the prevention and treatment of cervical cancer in the world, an African American who spent the last 20 years of his life or so, I think, in Zambia and elsewhere in Africa, treating women with cervical cancer and screening and preventing cervical cancer. And he's got a whole bunch of people around him who are not patients. There's staff that work with him, but I include Groesbeck's picture because he says when a patient comes in to see him in the office in Zambia, he can often tell she has invasive cervical cancer just by her appearance and, as he puts it, the odor she carries. And those of us who work in this field know exactly what he means. And so we can see a woman at presentation and know she has invasive cancer, and yet in that low resource setting, there are a number of barriers between that knowledge on an intuitive level and being able to get definitive diagnosis and treatment. And so some of those challenges are need for decision aids that not everybody gets to see Groesbeck-Parham. As I was saying, a lot of people go in, something's wrong, they have bleeding, they have pain, they go in to see a primary care provider, but no sense can be made of that presentation. And so if there could be some sort of decision aid to help with that, that could be tremendously beneficial. Is there some kind of novel diagnostic that could help with this? So we know that there was an issue, this has been investigated in some other cancers, and clearly, at least with more locally advanced cervical cancer, we know that there's something going on in the aura around the patient that could be detected and used. And so I'm fishing here for like a leapfrog technology that would get us past the need for doing an exam, taking a biopsy, getting the biopsy process, et cetera, et cetera. I'll walk us through that a little bit more. I don't mean to be unkind by making you look at a picture, however, abstract and tasteful of a pelvic exam. But I do put it up because it's important to remember that this is a pain point everywhere, and especially in a low resource setting. So this is a difficult moment, right? Now that appears to be a kind, gentle clinician doing the exam, but there's a loss of dignity, a loss of privacy, there's a need for a private room, there's a need for equipment. So there are a large number of things that are a challenge in a resource-limited setting just in the pelvic exam and biopsy. And if there were a leapfrog, we think there's a leapfrog now for HPV testing with self-swab. If there's something going on that would enable us to diagnose invasive cancer on top of diagnosing HPV, that could be a leapfrog technology, but also leapfrog that patient past the number of barriers that occur in a resource-limited setting. Oops, wrong way. So we got to do a pelvic exam, got to get the specimen, it's got to be retrieved and put in a jar of media, right, and a fixative. It's got to get transported to a lab. We've got to have information systems that will enable us to mark that specimen and associate it with the patient and follow the patient through her own journey, as Franklin was showing, back to her home, back to wherever she goes, as well as follow the specimen out to the lab through processing, through diagnosis, through the cloud, and somehow get it all the way back to the patient's home. And so also biometrics are something more advanced with being able to do patient identification. And sure, there are a lot of these, but to be able to do this securely, confidentially, and at low cost would be very attractive. So timely tissue diagnosis, this is something of an infamous slide on the right. This was published in I think the Oncologists, where a group of our colleagues from the Mass General went to try to help set up a radiotherapy program in Botswana, and found that one of the big bottlenecks of getting patients into radiotherapy was processing the specimens that came to the lab. And because nobody wants to administer radiotherapy or chemotherapy or do cancer surgery without a definitive diagnosis. But there were neither the technicians nor the reagents nor enough pathologists to be able to get these specimens cut in, processed, stained, and read. So timely tissue diagnosis all has to happen before we can plan treatment and select therapy. The specimen's got to be transported, it's got to be processed, they've got to be read, and then again, they've got to be able to manage those records. So kind of a nice picture, right? I show you this picture because there's a lot going on here. This is Mbarara, Uganda, where Franklin and I have both been a number of times. Kind of a boom town in previously rural southwestern Uganda. And I picked the picture because there's a lot going on. There's pavement, there's trucks going down, there's a new gas station, there's not really anybody sitting around, everybody's doing something. And there's a guy, the transport method for bananas is a guy with basically a steel bicycle pushing it up a hill. And so a lot of different things going on at once, and you can't assume low technology, you can't assume high technology. The answer is somewhere in this very organic mixture altogether. And so if you think about transport or following people through the system, that's the environment you're dealing with. Selection of therapy, I show these colleagues from Umbarara from the OBGYN department. These are senior nurses, or sisters as we call them, and they're outstanding clinicians, but they, needless to say, have not been given formal cancer training. And so if they see a patient with an invasive cervical cancer, they actually probably know because they're at a national referral hospital. But if you have somebody who's in their role at a regional or a local hospital, it's very difficult for them to know what this is, who do they call, what do they do. And so some kind of decision aid for that and an access to an expert opinion would be very helpful. I know I'm maybe talking more about information technology here than mechanical engineering, but just looking at that. And then the information technology to be able to have a timely referral and a follow-up would be very helpful. So say that person gets through all those barriers and then has a locally advanced cervical cancer. And the guidelines now, we now have enough evidence to say that in, for example, Umbarara, Uganda, there's currently no radiotherapy, but there is chemotherapy and there's surgery. And there's enough evidence to say that we can treat women with chemotherapy, and if they have a good clinical response, they can have radical surgery to remove the cancer, and that will often be curative. But then that would mean we need to do neoadjuvant chemotherapy, which means we need clinical laboratory capacity. It also means we need intravenous access. And what happens now is that patients get a peripheral IV every time they come in, and they may often come in every week or every 3 weeks, depending on the regimen. They may be very skinny or otherwise have difficulty with IV access. And the chemotherapy can be very corrosive to peripheral veins, and so that can be a challenge. In a high-resource setting, we do some sort of central access, usually through a peripheral access, but there's troubles with expense and with maintenance of the sterility of that in a low-resource setting. So some sort of device that could be a lower-cost IV access device would be very helpful. These are a number of my colleagues in the OBGYN department at the Umbarara University of Science and Technology. They're super good doctors, but again, they have not had formal cancer surgical training. They're really good with their hands. They're very skilled, and we do some cases together. But there's, if we could have help with remote conferencing and training with didactics, as Franklin was alluding to, and if there was some capability, people have tried Google Glass and it was kind of jittery and it didn't really completely work, but if some sort of possibility of perioperative and intraoperative consultation that could really strengthen the collaboration. And the same technology potentially could be used for assessment of skills. And I'll try to wrap it up, Helen, sorry. Patients in southwestern Uganda, for example, are by and large subsistence farmers. And so if they come in to get a surgery for cancer, they end up with a laparotomy, a big incision on their belly and an open surgery, which usually would take here, you wouldn't feed the dog for 4 to 6 weeks. You wouldn't lift anything over 20 pounds. There, nobody's digging in the dirt and making sure the bananas come off the tree until that woman's better. She's the one who's got to do it, is that middle-aged woman who comes in for her cancer surgery. And so that's one more reason that laparoscopic surgery rather than an open surgery, which has been shown to result in high-resource settings in comparable cancer outcomes, would be very helpful. On the left, I'm saying laparoscopic surgery could yield a faster recovery and lower morbidity, but we have challenges like sterilely instilling CO2 into the peritoneal cavity, monitoring the patient's CO2 levels during their anesthesia in a low resource setting, frugal but quality visualization. If we do a laparoscopy here at Longwood or down at MGH, you're going to use a high-def camera on a fiber optic scope that costs something around $40,000 US. Or you use a robot system that costs $2 million US. So we're obviously not going to want to do either of those in Umbarara. So some sort of frugal but high quality visualization would be extremely helpful in that situation. And similarly, a lot of the costs of doing less invasive surgery is due to these disposable and therefore not as robustly built instruments that are used in high resource settings. So more frugal, maybe more simple and more reusable instrumentation that could be used in that setting would also be extremely helpful. A lot of what we do in laparoscopic surgery, rather than cutting and sewing, is simply to use energy devices to seal the tissue and then cut in the middle of what we've sealed. And so some sort of more frugal energy source for that technology would also be very helpful. And palliative care, and I put, the patients need timely access to symptom relief, and there's an overall problem of access to opiates, as Franklin was saying, for pain relief. And I think one of those things is, one of the issues with that is just graft, things that could be sold at for a profit tend to disappear in low resource settings. But also the security, and this would be an issue that could be very helpful even in high resource settings, is some kind of device that could yield secure but convenient access to analgesics, including opiates, would be very, very helpful. Certainly in HIV treatment, they have pill boxes where the doctor knows back at the study site if a patient has opened his or her pill box to take the ART at certain times during the day, and could a similar device be engineered that would give a patient access to pill boxes at appropriate times? Couple things about effects of therapy. Patients treated for invasive cervical cancer tend to have bowel and bladder dysfunction, sexual dysfunction, lymphedema. And for treatment, especially for the sexual dysfunction and lymphedema, they tend to need physical therapy. They need things called vaginal dilators, which are, I won't say it because we're filming it, but they need vaginal dilators. And they also need lymphedema stockings and pumps. And those are, that's tech that's fairly expensive and clunky in the US. And obviously, again, this is something where your subsistence farmer outside Umbarara is not going to have a good time going back to the banana crop if she's got a leg like that right leg in the picture. And so some kind of low-cost way of managing that problem would be extremely valuable in this setting. And this is just to remind me to be quiet and remind you to help me save this kid's mom.